and welcome to the Home of Medicine podcast with me, Dr. Amy Burbridge. Today, I am incredibly honoured to be joined by...
Hi everyone, my name is Dr Sarb Clare. I'm an acute medicine consultant and Deputy Medical Director at the Sandwell and West Birmingham NHS Trust in the UK. Like Amy, an acute medic with a huge passion of making sure our patients get the best care possible. And I hope you can enjoy our next case. So happy to kick off, Amy?
Absolutely.
Yeah, let's go for it. So this is a patient, he's a 40-year-old chap, he's an Asian chap, and he gets referred to the medics because the GP had arranged an ultrasound and it showed a 15 centimetre splenomegaly, so he gets referred to us. But when it was presented to me by the junior, and the story's not just about the splenomegaly, but something's not been right for the past couple of months. So for about 8 weeks, he's been having recurrent seizures, which are described as tonic-clonic. He's been incontinent, he's been tongue biting. And he's not known to have epilepsy at all. Now, this chap has got learning difficulties, and he's also been labelled with having schizophrenia, although he's not on any treatment or really under anybody for that care. He's also got hypertension. And he'd been seeing his GP, his sort of parents have been taking him to see the GP because they're describing good-going seizures. But the GP hadn't started on treatment or done any further tests, but requested this ultrasound of his abdomen because he'd been complaining of abdominal pain and fullness. So really quite vague history, because we can't take a history from the patient because he wasn't communicating. So really quite vague, not much to go on at all. Any thoughts to start off with, Amy?
Where do I start?
Yeah. I think it goes back to taking a history again. And so it was really about me then speaking to because I couldn't get anything from the patient. Mm-hmm. So I got the parents in and said, what's been going on? So they described this 8 weeks of him, as I said, of good-going tonic-clonic seizures, intermittent, and he's having a post-ictal, so very good description of that. But also significant change in his behaviour. So this chap, because he's got learning difficulties, he was independent, he could feed himself, he could function, but then he just stopped doing that. So they had to feed him. He'd sort of become very lethargic. He also, he did used to speak, but he just stopped speaking during this time. And they described him having fevers as well, and some weight loss. They'd gone to the GP and described that the seizures and the fevers, and he'd had several courses of antibiotics with no real improvement in that. And when I examined him, he was just he was agitated and he wasn't communicating. And that's how it was sort of presented to me. So it's just very vague. Something's been going on for a couple of months.
Quite challenging as well, actually.
Yeah.
This is the type of case as well that in COVID would be very challenging because the relatives are unable to be with the individual.
Yeah.
So it's about how can you get a really good history over the phone? It's a different type of skill, isn't it? I think that we've all had to try and develop throughout COVID.
And also, he's agitated. Is he agitated because of he's not with his parents, he's in a different environment, he can't communicate. It was really challenging.
Yeah, absolutely. So we've got a 40-year-old gentleman who was referred to the medics, basically an incidental finding of this 15 centimetre splenomegaly.
Yeah.
And we don't know whether that's a red herring or has anything to do with the situation. But he's had a 8-week history of seizure activity. How frequently are they happening? Every day, every week?
Yeah, they're happening initially just every week and then increasing frequency about 2 to 3 times a week. Okay. And a very, very good history of description of a seizure rather than syncope or anything like that. Mm-hmm. So post-ictal, incontinent and tongue biting as well.
And did they film the seizure activity?
Sadly, no, they didn't do that. But so the history was all via the phone. Yeah.
And I think that's always a good question to ask the patient or whoever's with the patient. have you filmed it? And next time it happens, could you film it? Because everybody's got smartphones these days, and it's really good to actually visibly see what's happening with the seizure activity.
Absolutely, that's right. Yeah. And, you know, it was challenging because when it was presented to me, the junior doctor sort of, you know, said, well, I've not examined because patient's agitated. I've not been able to take a history because he's very challenging. So it was presented to me as a very difficult patient to deal with. You know, that sort of whole connotations, because they're difficult, we're not going to, you know, dig deeper and we're not going to examine. And therefore, I've just started them on antibiotics, and I think they might have encephalitis. So that's how it was presented to me.
I really struggle with that difficult patient label, because actually, is there such thing as a difficult patient? Or am I just not being very good at my job? I really struggle with the term difficult patient because it implies that the patient is doing something wrong or they're being difficult. But actually, as clinicians, really, we should be able to manage that and overcome that to give the patient the best possible care that they should receive. I am aware of visceral bias. It's that bias that you have that immediate reaction to somebody. You either like them, you dislike them. So, for example, they might really smell and you're like, oh God, they really, really smell. It's going to be challenging to get close to them. Or, for example, I know that they're in prison and they've been brought over. And it's all about not making judgment calls on that individual and going back to everybody's the same when we first meet them, and we have to treat them all the same. And be really aware of that visceral bias.
And when patients are presented to me like this, or they're being difficult or they're being aggressive, I always strip it back to the junior and say, but why do you think that? What's going on? And I think it's our role, again, to challenge juniors, because it starts from the beginning, doesn't it? It starts from, you know, the referral, the ED, into medicine, the nursing team, the wider MDT, and then suddenly the patient doesn't get the care, gets suboptimal care. There's no doubt we see that, don't we? And that's, we definitely play a role in challenging that.
Absolutely. And it's the same with very poor historian. I really hate that term, because I'm like, no, you're a poor history taker, or, you know, because we can't put, you know, I mean, I'm sure I used to say that when I started, actually, and I think it's only experience that actually it's not their fault. They're unwell, they're in hospital. Of course they're going to, there can be challenges. So it's my role to be really, really good at taking that history, teasing out that information.
And it's our role to be the advocate for the patient, to fight.
Absolutely. Yeah.
So there we go. So, you know, the junior is saying, well, difficult, can't examine, they're agitated. And, you know, you think, okay, so again, I remember seeing the patient in ED, that they were agitated, but that's not that's not a reason not to attempt to examine the patient, because the clues are always there. So I examined the patient and I found that the patient actually had some early clubbing, and his GCS is fluctuant from sort of 13 to 14, and he did have one spike of fever of 38, and I listened to his heart and I found a good mitral regurgitant murmur. And this is how it sort of all came together. And that's, for me, it was disappointing because the junior doctor had not examined the patient and the clues were all there.
And why do you think that sometimes we don't examine patients when we should?
I think it's a combination of, a huge reliance on other things, because we're now relying on, you know, tests, CTs, bloods, and so forth. Also, fear of maybe the patient lashing out. He was aggressive at times as well, and he becomes more of that as his time in hospital continues. He did become quite aggressive, so there's a fear of that as well. But I think, again, we just have to keep reiterating, it's, you know, I always say to our juniors, we are detectives, you know, and we need to find out as many clues as possible to put the story together. And okay, we can't get a history, but the clinical examination will give us some clues.
It's almost like I always say that medicine's an art, not a science.
Yes, I truly believe that as well.
Yeah. And, you know, I'd like to compare myself to Sherlock Holmes, but I certainly don't think I'm that clever. Okay, so let's go back to the patient then, and let's try and figure out what we're going to do next. So you've taken a history, we've examined him, you found this mitral regurgitation, you found some clubbing in the fingernails. Is there any splinter hemorrhages?
No, there's no splinter hemorrhages. No.
Okay. Pulse?
He's fine, actually. Hemodynamically, I mean, he was tachycardic at the time when he had his spike of fever, but apart from that, observations all normal.
Okay. Anything in the face to pick up on?
Nothing at all.
Okay. Examination of his chest?
That was lovely and clear. There's nothing there to suggest any infection or anything like that. Okay. And neurologically, he was moving all his limbs, so there's no obvious deficit.
Okay. And he had a mitral regurgitation, you said? That's
right, yeah.
Yeah. And JVP?
So, JVP was fine.
Okay. Any ankle edema?
No ankle edema. So no features of decompensation of heart failure or anything like that.
Okay. So investigations-wise then, blood tests.
So he had, all his bloods were normal apart from he had very... his white cells were upper limit, neutrophilia, and he had a CRP of 77, and that was essentially it. Normal renal function, normal LFTs.
Okay, urine dipstick?
That was all normal as well.
Oh, okay. ECG?
That was essentially, it was difficult to get because he was agitated, but when we did get one eventually, it was normal. There was no LVH or strain or anything like that.
Blood glucose?
Normal.
And given his slightly raised white cell count and his pyrexia, did you do a venous blood gas to find out his lactate?
Yeah, his lactate was within normal range as well.
Okay, so essentially, he's got normal bloods apart from a slightly elevated white cell count. Yeah. Okay, so actually, I'd like to CT his head.
Yeah, and that's exactly what it did. Yeah, because of the seizures. So basically, we had a young chap who's been having seizures, and also he's got splenomegaly. He's got this murmur and a bit of inflammation going on. So scanned his head, and essentially that showed something. It wasn't clear what it was initially. They said initially it was an infarct, but it was looking like perhaps a very small infarct, but perhaps an abscess as well.
Okay. And did he have a chest x-ray done?
Yeah, chest x-ray was completely normal. There was no consolidation or anything like that.
Okay.
But I used that opportunity on my post-take ward round then to take out my ultrasound probe and scan his heart as well. So I'll tell you what I found there. So put the probe on and it was like, oh my gosh. And he had significant mitral valve prolapse with a very large mitral valve vegetation.
Gosh.
So putting it all together, it all fitted. The jigsaw piece fitted.
What do you think was the final piece of the jigsaw that helped you make that diagnosis?
For me, it was that picking up the murmur.
Yeah.
The murmur was because he comes in with the seizures and the splenomegaly. So what we've got is a chap who's got mitral valve endocarditis due to mitral valve prolapse, so an abnormal mitral valve. He's throwing off his vegetations into his brain, into his spleen, and the ones in the brain are causing the seizures. But for me, it was that defining, listen to his heart, he's got a murmur, I need to put a probe on, and there was the answer.
What's really astonishing is in this individual who has got septic emboli, infective endocarditis, that his bloods are actually essentially normal.
Yeah. And this has been going on for approximately 2 months. Yeah. And this is another story of somebody who was not examined. So he's been seeing his GP. And what's interesting, so his GP was giving him, broad spectrum antibiotics because parents were saying he's got a bit of a fever. He's not right. So bit of coamoxiclav, and that may have dampened his response. But again, no one examined him, no one picked up the clubbing or his murmur was, anyone could hear it. And I was really disappointed that my junior doctor didn't listen to his heart, because that did cause delays.
It's, again, I think it reiterates, we do sometimes over rely on investigations when actually good history, good examination, you don't need the investigations. They help to clarify the diagnosis. They help to rule in and rule out. But actually, in this individual, the blood test wouldn't really have helped.
Yeah, absolutely. And I think for me as well, it's upsetting because the gentleman had learning difficulties and was labelled to have schizophrenia. And again, he was dismissed because of his underlying learning disability. So why did he not get examined? He was just labelled as being difficult. He was labelled, he's just got an infection. But actually he's got, massive vegetation on his mitral valve, which was, just embolizing everywhere.
And I think it certainly raises some really important points that is we could probably make a whole podcast to discuss how individuals with mental health conditions are treated differently by healthcare professionals, and the same for individuals with learning difficulties, because that is a bias in itself.
Absolutely. And for this chap, he was so distressed in hospital. He was at times, he did become aggressive. And that's where security was called. And we've all been there. And when security come, it's just awful. And he did need, sedating at times. He didn't understand what was going on. And it was really difficult to watch. But yes, he was challenging for the team, challenging for his parents, for him. But yeah, it's tough. But that's where I feel we need to upskill ourselves in how we deal with patients with learning difficulties.
Absolutely. Yeah, absolutely. And I think it's, again, something that you learn over time. It's, experience and being exposed to patients from every walk of life, and you work in different hospitals and you get experience of different individuals. I think it really helps. So I think that really goes back to medical school, and that actually we need to be exposing our medical students to everyone and everything from as early as is potentially possible to really ensure that we have that well-rounded medical student. So what was the patient journey then? What happened next?
So we got him under the care of cardiology. And again, what he demonstrated is because we got the diagnosis very promptly, very quickly, he got to the right place. But sadly, as I said, there were times where he didn't understand what was going on. He became aggressive. He wasn't complying with treatment. It was challenging to get a PICC line with him. So really, his vegetation was purely because of his abnormal mitral valve, and he was referred to the QE for mitral valve replacement. He did very well thereafter, but his journey was not great, his stay within hospital. And I often look back and I think, if I hadn't examined the patient, when would that diagnosis be made? It would have been picked up at some point because, he's in hospital and someone would listen to him. But it's interesting because the buck sort of stops with you. If I just said, okay, yeah, treat him with encephalitis, when would have been the next time somebody reassessed him and said, okay, this is not all fitting in. And I think it's probably worth us talking about that when we often see patients seen by other people. When should we reassess? When's the decision to do that? Do we reassess everybody? Do we start from the beginning with everybody and challenge the diagnosis? But yes, so he ended up having his mitral valve repaired, and he's doing well.
Fantastic. So it's a great ending to maybe not so good beginning.
Yeah. But I think again, it's that sort of same sort of headline messages. Stick to your basics, history, and if you can't get the history from the patient, then talk to the family. Examination. And the examination gave us all the clues, the splenomegaly, the seizures, and the murmur put it all together.
Absolutely. And I really liked your point about when do we go back? When do we reassess? When do we challenge somebody else's diagnosis? Because that is exceptionally hard to do. And particularly in a specialty like acute medicine, where you may be seen by a different clinician every day. because of the shift pattern, turnover. Whereas in general medicine on the wards, it can sometimes be different because you may see the same clinician every day. And I guess there's an argument about which is best. Yes, I don't know. But certainly I have made mistakes. I have missed diagnoses on many occasions. And I do, whether it's right or wrong, I reassess every patient that I see and I go back to basics. And I know that frustrates a lot of people, but for me, that's what suits me best. And I think maybe with time and experience, I might change, but that's how I can work safely for me.
Yeah. Yeah. And you're absolutely right. It's very difficult to turn a decision around as well that somebody else has made. So if someone says, okay, I think they need X, Y, and Z, and you think, why are we doing all these tests? It's very hard to change that around. But I also think on the flip side, if you're on the back wards, and I've worked on a lot of general medicine wards, you become, a bit lazy. You will just continue. You won't actually challenge yourself. And that's again where we do need our juniors and people to keep challenging us to think, okay, think outside the box.
Yeah, it is really hard. And also, I know that when I'm going to do a ward round now, I'm probably not as quick as I should be for acute medicine. And I know that some of the juniors will be like, oh God, I don't want to do a ward round with Amy today because she takes too long. So it is hard, isn't it, to find out,
but it's important that you feel happy that you're able to deliver the best care that you can, whatever method that is. And cutting corners always comes to bite you, and it's come back to bite me many a times. And I've cut corners. I've sent people home without waiting for their bloods back, and it's not the right thing to do. And sometimes you just need to wait. You just need to wait for things to, especially for our patients, just to come to fruition.
And I certainly think we underestimate the value of waiting and watching.
Yeah.
Because as acute physicians, we're all naturally probably things to be done really, really quickly. And actually, sometimes watch and wait is often the best treatment.
And I do worry, Amy, that acute medicine and ED, you've got all these targets, you must see patients quickly and this, but the natural history of an illness, we can't speed that up, and we need to make sure we give the treatments and make sure that they work before we take them, before we make a decision, because things change. And I think we are also disempowering our juniors because they're not getting to see everything because we're getting there before them. So that's really important that they get to see what happens to their patients when they, apply their management or decisions.
Yeah, I completely agree. So when I qualified as a junior doctor way back in 2005, medicine was very different then, in that when I was on call, I would see all the patients as a junior doctor and the consultant wouldn't see them and, for like 8, 9, 10, 11 hours. So actually, my history, investigations and management plan, I would see the patient journey through. Whereas nowadays, as an acute physician, I'm like, is there anybody to see? Fantastic. You've just clerked them. I'll post-take them straight away. And actually, there are benefits to that. But also, I think, there are some not so good things about that as well.
Yeah, absolutely. And I think our junior doctors have suffered.
Yeah, absolutely. I fully agree with that. Yeah. How can we change that then? How can we make the learning environment better for our trainees? What can we do as consultants?
Yeah, I mean, it's interesting because what we've talked about, there's actually studies out there and feedback from our juniors telling us all this, that we're disempowering them, that they're not getting to see the whole sort of spectrum of disease because we're getting there before them. But I think in a way, we're doing it to ourselves with us setting the target. So post-take within 6 hours. But actually, I mean, I like to empower my juniors and just go ahead. And I always like to say I'll see them later once they're the DKA, they're our DKA. There's no point in me seeing them before because so many things can go wrong. It's a difficult one because we've got so many pressures, haven't we, Amy?
Yeah.
So many pressures from the front door, the demand, lack of beds. It's about getting that balance. But I think us being proactive as clinicians and just teaching our juniors as many opportunities we can. And it doesn't have to be full teaching rounds. I mean, I just like to give snippets to them so that they take home at least 1 or 2 messages during their shift.
Yeah, Absolutely. And even if it is just one key important message that they didn't know the day before, and I often learn something new as well every day from my juniors. If I've done 5 days at work that week, I've learned 5 new things. So, actually formal education is challenging sometimes in acute medicine and in any medicine. So it's about finding those opportunities, isn't it? And taking them when you can. Absolutely. So if you could give me one takeaway message from this case, what would it be today?
For me, would be stick to your basics, history and examination. The patient, even if they don't speak to you, they'll give you the answers in some way. Absolutely.
And I think that's a really, really, really good point. Fantastic.
Thank you so much, Amy.
Thank you very much. Thank you to everybody out there who's listening. And if anybody's got any questions, you can email at amy@efimacademy.org or tweet me at Amy Burbridge. Thanks for listening. Goodbye. You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.